Hi everyone, my name is Jordan and I'm a medical student at the University of Calgary. Today I'll be talking about my project, Strabismus post-plaque brachytherapy for uveal melanoma. Uveal melanoma is the most common primary intraocular tumor in adults, with an incidence of 1.3 to 8.6 cases per million per year in the United States and Europe. Plaque brachytherapy has emerged as a novel, widely used treatment option with equivalent patient survival rates as traditional treatment techniques such as enucleation. However, it's been noticed that after plaque brachytherapy treatment, some patients develop diplopia and strabismus. And so the objectives of my project were to determine the incidence and type of strabismus post-plaque brachytherapy for uveal melanoma. For materials and methods, we looked at medical records from a total of 440 patients with uveal melanoma between October 31st, 2011 to October 19th, 2020. We collected demographic data involving patient age, gender, and residing city. And we also looked at outcome data, such as the presence of strabismus and diplopia and the classification of strabismus. All our plaque surgeries were performed by a single ophthalmologist under IV sedation, and the details of this surgery are provided below. For our results, a total of 11 patients developed strabismus post-plaque brachytherapy treatment. In terms of types of strabismus, focusing on table 1, 7 patients developed sensory strabismus, 2 patients developed decompensated phorias, and 1 patient developed slip muscle, and 1 patient had a palsied muscle. Focusing on figure 1, these are just the different types of plaque designs that are commonly used for plaque brachytherapy treatment. And so for a discussion, the incidence of strabismus in our study was 2.5%. This is comparable to published data in the literature. And so Dawson et al. Found a 1.7% incidence of persistent strabismus on 929 patients. Nagadrin et al. Found a 1.9% incidence of persistent diplopia amongst 329 patients, and Alfredi et al. Found a 2.8% incidence of persistent strabismus amongst 461 patients. And so a few theories as to why this occurs have been postulated. Number 1, strabismus post-plaque brachytherapy may be due to direct mechanical injury to extraocular muscles during surgery. Number 2, ionizing radiation damage to surrounding extraocular muscles, retina, and ocular tissue via unprotected laterally directed radiation from the plaque itself may also be causing strabismus. And 3, errors in muscle disinsertion during surgery, and they call that a slip muscle. In conclusion, this is one of the few studies to report on the incidence and type of strabismus post-plaque brachytherapy for uveal melanoma. Despite a low incidence rate, patients undergoing this surgery should be made aware of strabismus as a complication and sensory strabismus as the most frequent type of complication for strabismus. Thank you all. That concludes my presentation.